Welcome to the Johns Hopkins Women's Health Podcast, A Woman's Journey, Insights That Matter. I'm Kelly Gear-Ripken, and I invite you to listen to Johns Hopkins specialists discuss the latest topics in women's health. Now here's your host, Lily Shockney.
Hi, this is Lily Shockney from A Woman's Journey at Johns Hopkins, and this is our podcast, Insights That Matter. June is Alzheimer's and Brain Awareness Month. Today we are joined by Dr. Constantine Lyketsos, Director of Memory and Alzheimer's Treatment Center and the Director of the Department of Psychiatry and Behavioral Sciences at Johns Hopkins at our Bayview campus. So today you are considered and have been for some time a world expert in the care and the treatment of patients with Alzheimer's as well as related dementias. I think that's an incredibly challenging job. I have to admit that in looking at some statistics and figures, I about went into shock. So the Alzheimer's Association has estimated that Alzheimer's disease is the 6th leading cause of death in the U.S. That's very scary. 5.1 million Americans are living with this disease, and by 2050, which I know some people may think is a long time from now, but it's not, this number is projected to rise to be as big as 14 million. So when we do the calculations, that means that every 65 seconds, someone in the U.S. learns that they have Alzheimer's disease. That's really shocking. Cancer has always been the thing that people are most frightened of. And I think in the last, I'm going to say 5 to 7 years, cancer slid to position number 2. And Alzheimer hopped on up into position number 1. I do think that it's scary because consumers don't know a lot about it. They just know that they don't want it. But most people do know someone who has been diagnosed with it. And I think that that's where the fear and the anxiety do come into play. Can you first help us distinguish the basics between dementias and Alzheimer's, perhaps looking at what some of the distinctive symptoms are and when their onset from an age perspective might occur?
Lily, first of all, thank you for inviting me. It's a pleasure. I've always been a big fan of A Woman's Journey, and so I'm glad to see the podcast happening.
Yes.
So the dementia versus Alzheimer's question has got to be the question I am most frequently asked. And I'm still working on getting the answer right, but here's how I like to approach it. So I begin outside of the Alzheimer's area to see if a metaphor can be helpful. So if you go to heart disease, you might talk about chest pain, angina, and coronary artery disease. Chest pain is basically a nonspecific symptom that most people get probably every day, non-significant, goes away, comes and goes. Angina is what we call a syndrome. It involves chest pain, but the chest pain is a characteristic type. People describe it as a squeeze in the middle of the chest, like an elephant climbed up on you. And it's got other symptoms around it. So you might have nausea, you might get sweaty, you might feel the pain go down your arm. So we've gone from a pain symptom to a pain syndrome, describe angina. Mm-hmm. Well, angina is something a patient has and experiences, but coronary artery disease is where the arteries of the heart are affected and narrowed, or you get clots in them, and that reduces the blood supply to the heart, and that causes the angina. So the coronary artery disease is what's in the heart, the relevant organ in this case. So move to my sphere. We talk about memory loss, dementia, and Alzheimer's disease. So memory loss is like chest pain. We all have it almost every day. It comes and goes. We recover our memory, we lose it, and very benign, not something to worry about, even when you're getting older.
Forgot where you put the keys last night.
Exactly. Dementia is more like angina. It involves memory loss, but it's a characteristic type of memory loss, mostly for recent things, so you have trouble learning things. And there are other symptoms around it. So you have trouble getting organized. You might be disoriented and get lost when you're driving. You might have trouble managing the television clicker. It's a syndrome. And like angina, it's something that the patient experiences. It's a clinical state, if you will. Alzheimer's disease is in the brain. It's a particular appearance of the brain under the microscope that involves certain proteins that we call amyloid and tau, and also involves the death of nerve cells of the action part of the brain. When we talk about dementia, we're talking about a clinical state that we can diagnose in a fairly straightforward fashion. We don't need MRIs. We don't need fancy tests to decide if someone has dementia. But if we diagnose someone with dementia and we want to find out the cause, then sometimes we have to look for Alzheimer's disease. That's actually the most common cause that's in the brain.
What are the early warning signs of Alzheimer's disease, and are these early warning signs the same as what someone might see for dementia? So if I was evaluating, let's say, my mother, what might I notice that I should say, ooh, I better pay attention to this?
There are a couple of things to think about. First is how old your mother is, because if your mother is 50, you will attach very different significance to the symptoms I'm going to talk about as opposed to when she's 75 or 80. So the symptoms come in two boxes. And by the way, dementia is what has the symptoms. Alzheimer's what's in the brain. So we'll just talk about what dementia is all about. The two groups of symptoms are cognitive and behavioral. The cognitive symptoms are the one that we most often associate with Alzheimer's brain disease. And they have to do with memory loss for everyday things. So as you put it earlier, where did I put my keys? But in a way that you really can't find them.
Or you find them in the refrigerator.
Or you find them in the refrigerator. Or you repeat things. So people around you are hearing you ask 5 minutes later, what are we doing later today? And that's the 20th time that you've asked that question again. Losing things, forgetting things, and then getting anxious and worried about what you're supposed to do, starting to say, am I failing in some way because I can't think of it? So the experience of the memory loss starts in many people to lead to a reaction, an emotional reaction. And then there are these other organizational things and orientation things that can be early symptoms. So the classic is getting lost while driving. And the other one might be, well, you can no longer organize your schedule. You couldn't go shopping by yourself. Somehow you wouldn't be able to execute, keep track of the list, find things, pay for them, and so forth.
And we certainly wouldn't want someone dealing with this being in charge of their medications.
Exactly. So that would be another thing, is forgetting medications or starting to have trouble paying bills, which is another common early occurrence. So those are what we call the cognitive symptoms. We're appreciating that there's a whole other group of behavioral, or what we call them more technically, neuropsychiatric symptoms. In the common setting, common parlance, those are sometimes referred to as personality change. So it might be, my dad is changing. He used to be an awfully nice guy, and now he's becoming cranky and irritable. Believe it or not, the opposite happens too. My dad was a whatever all of his life, and all of a sudden he's nice to me, and I'm not used to that. He's changed, he's withdrawn, he's apathetic, and he's nice to people. Giving you extreme examples.
Yes.
So a kind of a personality change, meaning that a change is always there.
Are they able to remember things from long ago? Because that's something I've noticed before, is talk about 1940, and he can tell you everything.
Yeah,
but talk about this morning, and there could be a problem.
That's a very well put. Think of it as a dimension, so that when dementia is very mild, what you describe holds, is that someone might even remember last year or last holidays or 30 years ago, and not what happened this morning or it happened 5 minutes ago. But as dementia worsens, that sense of remote memory either gets inaccurate or gets forgotten. So it's not unusual for people to remember that something happened in 1940, but to fill in a whole new memory, a term we sometimes use is confabulation. So there's this emotional sense that something happened, but what they say isn't in fact what they knew really happened a few years ago.
Wow. Can we discuss some of the findings of recent research to uncover what are now believed to be causes, as well as what's been created for actual treatments for Alzheimer's disease?
Absolutely. So from early days of studying this disease, we've realized that if you look at the brain under the microscope, you find three major changes. One is these proteins called amyloid plaques. The other thing is these proteins called tau protein. And then the third thing is neuronal loss. The neurons actually die, so you have less tissue. The amyloid is the story that we understand the best in terms of how it gets formed. Amyloid is basically a cluster of the same protein. If you think about it, these little strings of proteins, fairly short, our body is producing them all the time, millions of molecules, and our body clears those pretty well. But as we get older, and this is where the mystery starts, they start sticking to each other, become harder to take out of the body, harder to clear, and eventually clump into plaques. So somewhere along from a single molecule to a plaque, there are little molecules that are toxic to brain cells, we believe. Then there is the fact that when the brain cells are affected by this toxic and they start dying, their internal structure, their cytoskeleton, starts dying out. So the nerve cells have a particular structure, depends on these proteins that have a mortar between them. That mortar is tau protein. With Alzheimer's, that tau protein gets altered, and so it can no longer function as a mortar. So if you can imagine, you've got this long semi-rigid tube, nerve cell is no longer rigid, and so it loses its connection with downstream, and the nerve cell dies off. So those are the things that we've known fairly well, and there have been efforts to manipulate amyloid, either to reduce production or to make it so it can't aggregate into plaques, or to take the plaques out of the brain. And in animal models, by the way, we've cured millions of mice from Alzheimer's disease.
Yeah.
We're still working on people. But the models have been very helpful. We have many medication strategies that have pulled amyloid out and haven't really helped people. We think that might be because we're giving it too late. We're giving these medicines to people who've had dementia, and so there's a lot of brain damage.
Yeah, the horse is out of the barn.
The horse is out. It's like trying to reduce your cholesterol when your heart is functioning at 10%. You can't, right? It's not going to make a difference. So now there are many studies that are giving these amyloid-busting drugs to folks who have no symptoms, but we know they have amyloid in their brain because of a PET scan. So there are specialized PET scans that can tell us that. And we'll have that
answer. And would
answer.
a PET scan be done because a patient has some symptoms or because of family history? Because I'm sure our audience probably wants to dial the number for a PET scan right now.
So these PET scans are still not part of daily practice. They are research tools. There are some types of them that may end up on where insurance reimburses them. Medicare really is they're thinking about it, so to speak. So right now you can get that PET scan if you want to pay for it, or if you are part of a study. In either case, you've got to have a doctor sign for it.
Right.
And if, from my point of view, there are some situations where I would order it, but it would not be in someone who's asymptomatic under clinical care. If you're asymptomatic and you wanted to know and have a PET scan, you could enter some of these prevention studies. You would have the PET scan, it's either positive or negative, and then if you're positive, then you can go into where you get the treatment, the amyloid-busting treatment, and then you wait and see if that's going to take the amyloid out of your brain and make it less likely that you get dementia.
Is there a website or some other source where our audience could go and take a look at the criteria to determine whether or not they'd be a candidate for such a clinical study, or a phone number that a coordinator could speak to them on the phone and say, yes, you're a match to be enrolled in this study?
So I think there are two best websites for general education. One is run by the Alzheimer's Association. It's alz.org. Pretty easy. And it's got parts for caregivers, for clinicians, and so you can find lots and lots of material on that.
Okay.
If you're interested in a particular clinical trial, then I would go to clinicaltrials.gov and put in Alzheimer's, and that'll point to you any study that uses a PET scan, because PET scan depend on a pharmaceutical. They are regulated by FDA, and they would show up in clinicaltrials.gov. So clinicaltrials.gov, one word, .gov.
Got it. You mentioned about proteins, and I live in the breast cancer world, and we're very dependent on how proteins overproduce themselves and such too. But I think for this audience, because they might be thinking protein, maybe I'm eating too much protein in my diet. So can you explain that we're not talking about the intake in food contributing to the protein that different parts of our body produces?
Yeah, that's well put, Lily. No, we're not talking about that. When you eat protein, let's say you eat some fish that has protein, your body breaks the protein down into its parts called the amino acids. those do come into your body and get used to make your body's needed proteins.
Yeah. Can't you see people altering their diet in a considerable way, perhaps not to their benefit? Can you talk a little bit about the progress that has been made when we're taking a look at catching things earlier than what we've caught them before, so that medications perhaps can be of greater benefit rather than being given late when there's already so much damage that's already been done? It would be very difficult to recover, to go backwards. We can't rewind that DVD, unfortunately.
Unfortunately. Maybe introduce a little bit of background to make the point that the protein changes seem to be happening in the brain many years before any symptoms. We then have a period of mild symptoms where people are basically functional, but they're changing. Either their memory is changing or their personality is changing in some way. And that's what we call the mild cognitive impairment period. And then we have the dementia period. So right now, there are studies that are asking the question, if we go to the asymptomatic period, can we give a medicine? If we go to the mild symptoms period and we give a medicine, does that help? But there really is no evidence now that anything will work. Yes, we could give you a PET scan and in theory diagnose you, or at least come close to diagnosing you when you're 75 and normal. But I wouldn't want to do that right now. First, because there's a bit of uncertainty about the test. You could be 75, normal, have a PET scan that's abnormal, and be fine 15 years later. Okay. So I don't know the precise risk of your getting dementia. So I just want to emphasize for this audience that those PET scans are still very experimental. Okay. And there are no medicines that would couple them. However, being a researcher myself, I would encourage people to being part of the research world. Many volunteers for our research projects are children's or siblings of people with dementia who, like me, really want to find answers, and they volunteer for the various studies. So whether it be through alz.org or through clinicaltrials.gov, they can see the menu, if you will, of the available studies that they can volunteer for.
What the options are, and I'm a big advocate for participating in clinical trials. I seek out clinical trials myself as a cancer survivor to see what might I be able to contribute to science and research to pay it forward for others that are now coming along behind me with the same diagnoses.
Exactly.
What can someone do to have a healthy cognitive longevity? So let's say I'm 65. What would you advise me to do going forward?
So there are 3 or 4 basic tenets. The one is you want to maintain your health as good as you can, your general health. So I typically connect that with have a primary care physician who's good, go to them regularly, and make sure that they appreciate that you're aging and the kinds of things that might happen. In that context, I encourage that family members be part of it, because if people develop memory symptoms or dementia, they don't usually notice them. And in the primary care 10 minutes that docs have, they might not pick it up. Whereas if you establish with your primary care doc that it's okay if your kids call them up,
right,
that's an important thing. That
or
way
even go with them.
Or even go with them. Have that channel open. So a good primary care doctor who knows what she's doing and who's prepared to engage your family around you. The others come down to what I call the 3-legged stool, which is mental exercise, physical exercise, and social engagement. And they all matter. The principle that's followed by those, well, the 2 principles. One is if you don't use it, you will lose it.
Yep.
The brain's a muscle. And if you've been using it at a certain level because of your work activities or your exercise throughout your life, and then all of a sudden you stop doing that or you retire, that muscle is going to atrophy. So you really should keep it going. I'm a big proponent of never retiring. I think it's an artificial concept, but people certainly like retiring, and they will do it. The other principle here is variety.
I think it's a matter of what you do when you retire.
Yes.
If you become a couch potato, that's not helping you or anybody else.
Yeah, but most people...
But if you remain productive in some manner, I think that's very smart.
I agree. But I mean, there are many reasons why most people don't remain as productive as they could or should. There's always, on average, a reduction in productivity. The other principle is what we call variety. And the idea here is that the brain is a muscle with many, many submuscles. So that if you're just exercising by jogging, you're going to help the jogging part of the brain. But the other parts of the brain, if you're not using them. So you should vary your exercise regimen over time. You should vary your mental activities over time. You should vary your social engagement over time so that through variety, you're engaging as much of your brain as possible and you give all of your brain a chance to keep going.
I like that. That perhaps would be an incentive for grandparents to sit down and play some board games with their grandchildren.
Yes. Lots of things. And these cross-generational ideas are wonderful.
Yeah. I also think that children are very intuitive in picking up symptoms that adults may not pick up. I've seen that in my own family, where a grandchild said, I can tell there's something different here that I wasn't seeing before. And the analogy that she gave was this person is like Dory. In the Disney movie, it was a fish who had a memory problem. So she understood it far better than anybody else and said, I know how to have a conversation with this person then. And I thought, boy, children are so intuitive. We need to continue to learn from them.
How true. In my native Greek, there's a saying that you learn the truth from children. And that fits. I mean, you learn the truth from other things according to that saying, but we'll focus on the children.
Yeah, absolutely. So if I could fast forward to, say, 2050, when we're going to have millions and millions and millions of people dealing with this disease, where do you think we might be from a research perspective?
Well, let me backtrack before I answer that and make the point that even though we don't have cures right now, we actually do have fairly effective treatments that change quality of life, that help people live at home longer, that help caregivers do better. So I wouldn't underestimate the situation that we're in now. When I started in this field in the early 90s, it was a warehousing attitude. It was a diagnose and adios. You didn't want the diagnosis. It was a label. It was a death sentence. You'll probably be in a nursing home next week. Absolutely no longer the case. There's lots of things that we can do, which is why we try to emphasize early diagnosis for the purposes of planning, but also to implement a variety of therapies. And because we don't have curative drugs, medications are only a small part of what we do. Lots of other things. So now fast forward to 2050. Hopefully we will be closer to where we can prevent or stop so that the counts of people will go down. I think from the medicines that we have in the pipeline right now, that's unlikely to be the outcome. The medicines that are in the pipeline right now seem to be delayers. And so they might take what's a 12-year illness and turn it into a 20-year illness.
Got it.
And therefore, we might actually have more people alive with the disease because of these new medications. But hopefully, they'll be in much less disabled stages, much milder, where they can have a reasonably good life quality, where they can be engaged with their families. Good functional
status, yes.
So I'm always hopeful, but I start with there's a lot we can do now, and we're never going to lose that. And so it could only get better than what we have now.
That's very helpful. So I think about our audience today who's listening to this. Many of them are baby boomers, and they are thinking about where they're headed in the future. They may be already taking care of their parents in some manner, whether it be for physical reasons or for cognitive function reasons. And they are taking a look at where am I going to be at 2050. So I think that's incredibly helpful. Well, we are fortunate to have you here at Johns Hopkins, not just as a provider, a clinician, but also doing very much needed research so that we can keep making our best better here. And it gives me hope for my generation and future generations. So thank you for joining us today.
Thank you. It's really been my pleasure.
Thank you for listening to A Woman's Journey podcast. Join me, Kelly Gear-Ripken, your host, Lily Shockney, and a variety of Johns Hopkins experts on the first Thursday of each month to learn about medical advances in women's health. A Woman's Journey is grateful for the unrestricted educational grants from Biosense Webster and Boston Scientific that support our podcast series, Insights That Matter. For more information about A Woman's Journey, visit our website, hopkinsmedicine.org/A Woman's Journey. And like us on Facebook and Twitter. Until next time, stay well.